Good evening and welcome to the Cure HHT webinar series. I am Nicole Schaefer, Director of Professional and Medical Programs for Cure HHT. I'm welcoming you tonight to this evening's webinar, HHT, Caring for the Younger Generation. Just a few reminders. Tonight's call is being recorded and will be posted on our website at www.curehht.org. After the webinar, you will receive an email with a short survey. Your input is critical to the development of future webinars, so we do appreciate you taking the time to fill this out. To help reduce background noise, we have muted everyone's phone or microphones, but you can ask questions throughout the webinar by going to the gray panel on your screen and typing in your question. I will ask the presenter as many questions as time allows during the second half of the call. Also in the panel on your screen is a section for downloading documents. There are 5 handouts that we've put onto this webinar, and you can download them to your computer during the webinar, or it will be available on the recorded version of the webinar on our website. Also, we ask that you please ask your general questions related to tonight's topic so that the answers will benefit everyone on the call. Now, it is my pleasure to introduce our speaker. Lynne Sekarski is currently a nurse coordinator in the HHT Center at St. Louis Children's Hospital at Washington University and in the Adolescent Medicine Division in St. Louis, Missouri. She has been involved with HHT since 2002. Lynne has 30 years of nursing experience that includes pediatric intensive care, pediatric lung transplantation, HHT, and general pediatric and adolescent patient care. She is also an adjunct professor at Goldfarb School of Nursing and is a board-certified pediatric nurse. I now pass tonight's program over to Ms. Sekarski.
Thank you. Thanks, everybody, and thank you to Cure HHT for inviting me to speak to you and spend our early evening together. My name is Lynne, and I'm a nurse at the HHT Center at Washington University. Just a couple sentences about us. Our center treats the whole family, meaning from infants all the way through adulthood. We have a freestanding children's hospital, St. Louis Children's Hospital, and we see patients from infants to age 18 years. And our counterparts, the adult program, sees patients 18 years and above, and that's at Barnes Jewish Hospital at Washington University. We have many, and our buildings are literally just through a covered walkway, so families can come. We can coordinate appointments for the children, the parents, and their grandparents. We have many dedicated HHT team members. Our co-directors for the adult program is Dr. Murali Chakanala, and the pediatric co-director is Dr. Andrew White. So let's get started. For tonight, my objectives for you is to be able to define HHT, define how it presents in children, how we screen children for HHT, treatment options, and some other miscellaneous things along the way. This is a typical list of phone calls that we get in our center. Patients call up, and we're going to discuss some of these scenarios. The first call: my child has been treated for pneumonia twice and isn't getting any better. Could this be something else? Another person will call: my mom took my daughter for her annual physical and her O2 sat was 85%. Usually your oxygen level is greater than 95% normally. I have HHT but didn't think I had to worry about my child. Is this concerning? Another one: we were told that we all have a bleeding problem and there isn't much to do about it. Is that true? Several of my family members have nosebleeds and we are seeing more red spots on our skin. Is this a disease? And finally, I am pregnant and I have HHT. When can we test our baby? These are all great questions, and I hope that we will definitely answer all of them as we go through the talk. We have to go through some of the basics first. So what is HHT? HHT is short for, thank goodness we can say HHT, because it's hereditary hemorrhagic telangiectasia, or also Osler-Weber-Rondeau. It's a genetic disorder, autosomal dominant, meaning that you only need to get one gene from one parent in order to have HHT. Each parent, gives their child 2 genes, and you only need one gene passed down to a child to have HHT. So there's a 50% chance of each of your children having HHT if you, as a parent, have HHT. We know there's at least probably 5 different genes involved, but that is growing. The main genes are names like endoglin, ALK1. Those 2 genes make up 85% of people with HHT. And then there's also SMAD4, which is related to juvenile polyposis, and then a couple other genes that recently have been found to cause HHT symptoms as well. And it is present in about 1 to 5,000 people here. Males equal to females. There's no difference in the presentation. It's an abnormal blood vessel disease. So the blood vessels, some of the blood vessels in your body grow abnormally. When we're talking about small blood vessels, we talk about the little spots that you see on your tongue and your lips and your cheek and your fingernail beds, your skin, fingers, GI tract. When we're talking about the large blood vessels, we're talking about AVMs, which is an AVM stands for arteriovenous malformation. And those, which I'll have pictures to show you later to explain it a little bit better, are in solid organs, like on my little cartoon up there: brain, spine, liver, and lungs. So in 1999, the Scientific Board of HHT Foundation, or Cure HHT, put together the clinical criteria, or the Curacao criteria, to make the diagnosis of HHT. And these criteria, which will be on the next slide, if you have 3 of these things, you definitely have HHT. If you have 2, you have possible or suspected HHT. And if you have less than 2, really you probably don't have HHT. And just to give you a little bit of frame, HHT was first found in the Dutch population, and although I said earlier 1 in 5,000 people here, on the island of Curacao and Bonaire, 1 in 1,300 people have this disease. So it's very prevalent. So to make the diagnosis, here's the criteria. And this is, again, a clinical diagnosis. And it can be really difficult in kids, which we'll learn about as we go on. Epistaxis is the fancy word for nosebleeds. Spontaneous, recurrent. Telangiectasias are those little small blood vessels that I told you were abnormal. They're multiple at characteristic sites: your lips, oral cavity, fingers, nose. And then visceral just means solid organ lesions, which are GI tract. Pulmonary means lung AVM, hepatic AVM, which is liver, cerebral is brain, and spinal AVM is in your spinal cord. And then a first-degree relative, like a sibling or a child or a parent, with HHT. So I think the biggest thing in kids is that you might just have nosebleeds or a red spot, but that doesn't necessarily mean that you have HHT. As we move forward, because people with nosebleeds and red spots don't necessarily have HHT. Again, here's some of the organs affected by HHT, and that would be the nose, the skin, the red the red spots, the mucosal surfaces, lungs, brain and spine, GI tract. And you must know, and I'll stress this a lot, that HHT does not affect every family member the same way. There is much variability of symptoms within the same family. And again, I think that's why some people in the family say oh, I know I don't have that because I don't have nosebleeds or I don't have the red spots. But we're not really, that can be misleading because you still could have HHT. So children, we're the pediatric people. Children are not small adults. They can have nosebleeds and red spots and not have HHT. It makes our job really hard. We have a lot of screening and things to do with the kids. It's a little bit different than adults. And children with HHT might not have nosebleeds or red spots. Diagnosis is harder without a solid organ AVM or a positive genetic test. A solid organ AVM meaning, a lung lesion or a brain lesion or something like that, and a positive genetic test, which is now, if we know the genetic marker in the family, we can test for that. And I will talk more about that as we go through the talk as well. Clinical manifestations, we're just going to talk about all these. Nosebleeds, 90% of HHT patients have nosebleeds. They're the most bothersome symptom that we see in children, which is good. I mean, that's really the most common symptoms we see. Average age of onset is 12 years, but some can begin when they're a baby. The types of nosebleeds that we see are very different. Sometimes they're just a lot of bleeding, sometimes hardly any, oozing, or they can be really hemorrhagic and last 45 minutes. Some are daily, some are rarely have any, and some don't have nosebleeds. And I'm sure that those of you with HHT that are listening, you have members of the family that fit all those categories. In children without HHT, nosebleed is rare if they're less than 2. You just don't see young kids or toddlers with nosebleeds. Excuse me. About 30% of children under 5 have nosebleeds, and over 5 years of age, maybe 50% of children are having nosebleed. It is a common reason for parents to take their child to see the doctor. And most of these nosebleeds are just managed through supportive care, lubricants, humidified air, just supportive things. They don't require an ER visit or anything like that. In children with HHT, given our limited data from a study noted below, 1/3 of the patients have nosebleeds by age 10 years, and 80 to 90% of kids have it by age 21. And of course, 95% by age 40, and 78% of our kids, so those patients that we follow from birth to age 18, have nosebleeds. So let's get started and talk about some of the patient care scenarios, since I know some of you probably have similar stories. Scenario number 1, my daughter has terrible nosebleeds and we have seen an ENT physician, which is an ear, nose, and throat physician. He believes she may have this disease that I cannot pronounce. He called it HHT. Is this what she has? So first of all, when we get these calls, I can't stress enough why people, other coordinators, the first call or the first person to triage the call that you make to a center, ask a ton of questions. We just need to know. We're kind of playing investigator, CSI, because what we find in the history will really help us tell whether you need to visit an HHT center or not. And these are just some of the questions that we're going to ask of nosebleeds. What is your history of nosebleeds? How often do they happen? How long do they last? And who has them? Have you had to go to an ER? Has your child had to go to an ER? Did they ever cauterize or use a little machine to stop the bleeding? Are they seasonal? Do you have allergies? And then we ask other questions about family history of other symptoms of HHT to see if, there's just anything else. And then, is there enough data regarding these nosebleeds to bring you to an HHT center here or any of the centers? So this patient was an 8-year-old girl, And again, she had been seen by her ear, nose, and throat doctor at a local hospital, and she'd had cautery 3 times for a nosebleed that wouldn't stop. And that doctor, at the time, he didn't have any planned follow-up the last time, and just see as needed as he had after all the other procedures. Well, upon the mom and the girl leaving the visit, the doctor looked at mom, and that lesion is what she saw, or the doctor saw, and he said, "You have HHT." So again, now it didn't really come to him till he talked to the parent. And after that visit, then the mom went on to be diagnosed and have genetic testing, and a gene was identified, and she had clinical screening and took care of herself. And then, we saw the children at our center. So this 8-year-old girl ended up having the same mutation, and that's HHT1. She had 2 pulmonary AVMs, or those 2 abnormal blood vessels, on her chest CT. And then she also had red spots on her fingers and nose and lips, and then she had nosebleeds. And her sibling was negative. So she's doing really well. Her lung AVMs were so small that they haven't required treatment, and we have just been watching them. So she's, we've been following her for 10 years or so. So that's one case. And again, just some treatment options. I think I know the adult centers more focused on treatment for nosebleeds, but thankfully in our kids, most of them, we just use this supportive care, which is nasal hygiene using saline drops, Vaseline, keeping your nails trimmed, avoid picking your nose. That's my little word there. Rhinotolexis is picking your nose. Don't do it. You got to keep, because every time somebody puts something foreign, like their finger in their nose, then they break the scab of the little telangiectasia, and it starts to bleed again. The other things you can use are bevacizumab, or the Avastin, estrogen, tranexamic acid, or Lystida. We have used tranexamic acid in a couple patients, but we have not used any of those other therapies, just because the situation hasn't arisen for our kids. Vasoconstrictors, like using Afrin on a Q-tip, occasionally, we've recommended that. The other therapies that are available, or people may need if their blood nosebleeds are so bad, as blood transfusions, iron transfusions, and many adults are very familiar with that. Estrogen therapy and other antifibrinolytics. Again, more treatment is, there are situations where you have to use cautery or a fine laser. We don't recommend it unless it's really the last option, because we know that once the laser's used, that new blood vessels can grow around it. But it has to be used in some points. Other types of treatment for nosebleeds are the intralesional injections of Avastin and Sotradecol, and septal dermoplasty, which is some surgery to help put new skin where the telangiectasias are in the nose, and embolization of a vessel that might be feeding telangiectasia in the nose. Thankfully, in kids, we don't have to use a lot of these treatments, but I needed to mention them. Here's just a typical family. These are the kind of people we see. They're from all over. And, there's a 50% chance that each child has HHT, and that was the case in this family. And I'm just so glad that you're listening, so that if you have kids, grandkids, nieces, and nephews, then we can get them screened and offer guidance and treatment. Another clinical manifestations after nosebleeds are telangiectasias and red spots. 95% of people have red spots by 30 or 40 years. They're mostly face, lips, ears, hands, forearms, tongue. You can see that's a really tiny red spot, and if you're not looking for it, you wouldn't think anything of it maybe. So in children, it could just be very minor like that. It's really hard to see. Here's some more pictures. HHT telangiectasias tend to be small, 1 to 4 millimeters. There's angioma-like. You can blanch them, meaning if you pull the skin, you see at the tip of it, it's a blood vessel. So if you pull it, the blood pulls away from the skin and then it refills. And that's one of the ways that we can tell that it's a telangiectasia. Spider angiomas are present in 15% of healthy preschool children, 45% of school-age children. They come and go, and they're also more common in pregnancy and liver failure. I have a few more pictures of these telangiectasias. And yes, some of these are adult pictures, but they're just good pictures of these red spots, so I use them. There's some kids, and yeah, excuse our ink, but we do draw on our little kids sometimes, if they allow us. Here's Dr. White looking for these small little telangiectasias in one of our patients. And again, here's some more photos. You know, some of these can be really small on the lips and inside the lips and tongue, and we just take a very careful look. And any of the HHT centers will do that because we know what we're looking for. Here's just a random picture I wanted to put. One of our patients did have a retinal telangiectasia, and that's just one of the pictures of a little bit of a bleed from that. Again, many children with and without HHT have red spots. And in our data of the patients that we have seen for pediatrics, 65% of the patients have red spots or telangiectasias. They develop over time, and absence or presence does not diagnose HHT. I know I said that before, but it's so true. We can't just go by the red spots and nosebleeds. So on to the next manifestation of HHT are clinical manifestations of pulmonary AVMs. 30 to 50% of adults have PAVMs. 60% of those have multiple lesions, and 90% or most of them are just a simple abnormal vessel, which I will show you a picture of here pretty soon. Symptoms. The big thing, number one, is they might not have any symptoms or any symptoms that they think are symptoms. Other people will be blue. They'll have cyanosis is what that means. They'll have blue nail beds or lips, so they'll be kind of purplish because they will lack a normal amount of oxygen in their blood. They will have exercise intolerance or be short of breath. They could cough up blood. They might have a low oxygen level, like less than 92% or less than 95%. They could have pulmonary hypertension, which is a high blood pressure in the lungs, stroke, or migraine headaches. And what is an AVM? Here's a picture on the left of what an arterial venous malformation looks like. You'll see on the left the artery is red because that's the oxygenated blood, and then it goes through capillary bed, which filters out air, blood clots, any particles or bacteria. And in HHT, there is no capillary bed, and you can see that that artery is directly connected to a vein. So it causes, you know, this high pressure flow, which makes the blood vessel weak, so it's susceptible to bursting and bleeding. And also then if you don't have that filter, then particles can go through there like a clot or a bacteria and cause abscess and other things. But that's the difference in a nice little picture. When I talked about simple AVM versus complex, you can see here a simple AVM is just the one feeding vessel with this little knot at the end, and the other one on the right is complex, meaning it has a couple different feeders. We call them feeder vessels. So in children, 40% of children have pulmonary AVMs. 30% of our patients do. They may be asymptomatic, again, or unrecognized. They could have trouble keeping up with their peers during gym class at school, or it may be mistaken for asthma. Hypoxemia means they have low oxygen level, but we might not know that because it may not be checked. They could be blue or have bluer nail beds, but maybe nobody compared them to anybody else. Polycythemia means they have an increased red blood cell count because their body is trying to increase the amount of oxygen available to it. They could have migraines, and migraines we know are associated with pulmonary AVMs, really, instead of brain AVMs. And there could be stroke. And the other symptom that is not listed here, but some patients actually present with pulmonary hypertension, and that was on the other slide for the adults, but that's an increased blood pressure in the lungs. Continued more pulmonary AVMs in children is just a summary. They could be present at birth. They might develop during childhood. They may develop and grow during adolescence. Some develop during adulthood, and for most, the growth appears to be slow. We still have a lot more to learn about the development of pulmonary AVMs and these vessels, when and why, and when to treat, when to wait. I think that's one of the focuses of research that Cure HHT has been helping us with too, is we just have a lot to learn about the kids. Scenario number 2. So this is a call. My son, 15 years old, was recently in the emergency room after a skateboard accident, and he was found to have no injuries related to his accident, but they were concerned because his oxygen level was low. It was 85%. So that's the little pulse oximeter on his finger is 85%, but otherwise he looked well. Mom says, I have HHT in my family, but I didn't think I needed to worry about it until he was an adult. Again, your O2 saturation should be about 95% or above, and this patient hadn't been screened. So here we have at the outside hospital a 15-year-old boy in the emergency room with low oxygen. Chest x-ray was suspicious for pulmonary AVMs or lung AVMs. Chest CTA, which is a chest CT with angiography, it's a fancy picture, was positive for pulmonary AVMs. No brain lesions. He did have a positive clinical family history because mom had HHT. So he also had clubbing of his fingernails, which I say down there. So he came to our HHT center having had those studies done, and his O2 sat in our office was 88%, so still low. He had nosebleeds, he had telangiectasias or the red spots. He had blueness or cyanosis of his nail beds and clubbing, which actually, it changes the shape of the fingertip because of the lack of oxygen over time. So that develops over years. At our center, we had embolized 3 pulmonary AVMs with feeding vessels of 5 millimeters. Most centers will can embolize lung AVMs if the vessel is 2.5 to 3 millimeters, but his were quite big. And he also was found to have a mutation in the endoglin gene. So we always say we're thankful that this young man liked skateboarding because it could have saved his life. Like, we found that he had HHT. So on to some of the screening tests that we would do for HHT, and we just talked about for pulmonary AVMs. These are non-invasive tests. There's no radiology, but the first test for patients and kids is a non-invasive test called a bubble echocardiogram. And the bubble means that we do a heart ultrasound, which you can see in the picture. They put gel on your chest, and we put a probe there, and we can see a picture of the heart. But what we want to know is if there's any abnormal shunting or that vessel that I showed you pictures of. So we actually agitate or shake saline in a syringe to give it some bubbles, and we inject it through an IV in the arm, and we watch the bubbles go through the heart system. When the bubbles go through a normal pulmonary vasculature, the oxygen the air in these bubbles should just be breathed out, and you shouldn't see them on the left side of the heart. They should go through that capillary bed and just be expired out in the air. But if it's abnormal, you will see them on the other side of the heart. And I'm going to show you a picture in just a minute. Just for those of you, worried about some of these tests in kids, at our hospital, we take great care to talk the children through this test. We have child life specialists that sit with them. We have iPads. They can play with an iPad while they're getting a test like this. We always use topical anesthetic before we start the IV, if it's their choice, but we can put cream on called EMLA, and we let it sit, and then we can start the IV, so there's really relatively little bit of pain. And again, we really use our child life specialists here at St. Louis Children's Hospital. So here's our picture of our bubble echo. Many of you have already had one. You can see gush of saline right there on the right side of the heart, and after just, we wait 3 to 8 cycles, and you see that there's bubbles on the left side of the heart, and they should not be there. We'll do that one more time so you can watch it. The saline is injected right there, and the bubbles should go out the lungs, but you can see that there's bubbles on the left side of the heart. This is a very positive bubble study. We would say that's a lot of bubbles. So this person we would recommend a chest CT to further define whether or not there's a lung AVM. If there's just a few bubbles on one of these studies, it's very subjective in kids, we may just wait and repeat it in a couple years. But that's a positive bubble study, and we would go ahead and do a chest CT on that patient. And here is what I mean by a chest CT. There's arrows that show you that pulmonary AVM right there with the arrows, where there's a feeding vessel and a little glob of vessels that are tangled. Here's a couple others. You can see it just looks like a little bleb, and some people call them that too, but you can see what that looks like on a CT scan. So for the pulmonary AVMs, out of our patient load, 30% of our patients have pulmonary AVMs on a CT scan, and or else they found it when they did angiography in the OR setting. 30% had shortness of breath as a symptom, and they also had a low oxygen level, which is less than 97%. So a third of our patients basically had symptoms, but look how many people didn't have symptoms. 70% of our patients didn't have a low sat or think they were short of breath. So we will embolize most patients if the feeding vessel is over 3, and especially if they're symptomatic. In order to treat these, you'll see the picture. It's similar to a cardiac cath. The patients are brought into an outpatient setting, and they're offered, again, pain-free IV start and anesthesia. The procedure is finished in a few hours, and they do recover there for maybe 3 or 4 hours. We ask the patients to stay in town, but they don't. Hardly anybody spends the night in the hospital unless it would be a young infant, maybe less than a year old or less than 2 years. But most patients, we have them discharged from the hospital after the procedure, which means that we're putting little coils, and I apologize, I don't have a picture of the little coils, in the abnormal vessels, and we're stopping it up, and we're making sure that no blood flow goes through that abnormal vessel when we're finished. I say we. I don't do this procedure, but an interventional radiologist does. And then we will just monitor them after the case, just really rest the next 24 to 72 hours. They may have some pain inside the pleural cavity, which we call pleurisy, and it's very painful. About a third of the patients have that. We ask them to use Tylenol or other meds until the pain is gone. It doesn't happen, like I said, in a third of the patients, but our patients get to go home the next day from our town, and if they have any problems, they get back to us or call us, but there's just been very few. I can't even think of any. Maybe one patient that had pleurisy and gave us a call. Again, here's a picture during the embolization when they're putting the coils in. Couple other pictures. The next clinical manifestation to talk about is brain AVMs. Brain AVMs happen in 15 to 20% of adults, and about 10% of our patients have brain AVMs. There's a chance of intracranial or brain hemorrhage, about 1% per brain AVM per year, relatively low. Most people with brain AVMs have central nervous system manifestations or neurology manifestations, but most of them are due to pulmonary AVMs or the blood flow in the lungs 60% of the time. And you could have emboli, stroke, a brain abscess, and you have that abscess because remember, you don't have that capillary bed to filter out that bacteria. And you also have migraines. Here's a picture of a brain lesion on one of our patients. This is an MRI scan. Here's another one. Here's one in the spine. And again, this patient came to us, was an asymptomatic 10-year-old, and we found this, like no symptoms, healthy, doing everything a 10-year-old should. And this is what we found on just a screening. She hadn't had screening before, and she was 10 when she came to us. Let's talk about another patient. So we're here because my mom, grandmother, and I were just diagnosed with HHT. Should I be concerned about my children? Again, the children were asymptomatic, meaning they didn't have any symptoms. So grandma was diagnosed with HHT through a GI bleed, anemia, shortness of breath. Mom had the diagnosis made from genetic testing, and she went on to have clinical screening. So since we know the genetic mutation on mom, we went ahead and tested both of the kids. Well, one of the children ended up having HHT1 or endoglin, and the other child was negative. So the patient came to our center for screening, the 10-year-old, and had a physician consultation, bubble echo, brain MRI, and the patient had a positive bubble echo, meaning there was bubbles just like that picture I showed you, and pulmonary AVMs on chest CT. Went on to have 2 of those embolized, and then the patient also had her brain AVM surgically removed. And then we just offered, guidance for her to come back in, a couple years. Usually after we embolize the pulmonary AVMs, we want them to have a repeat CT in, 18 months to 2 years to check back on things. Again, that's a patient scenario where they weren't screened, nobody in the family knew they had HHT until grandma was diagnosed. But I think this family knew that they had to be concerned about the kids, and they brought their children to be screened. Some treatments for brain AVMs, embolization, again, cauterizing, putting coils, glue, there's all kinds of things. Gamma knife, which we use on the peds patients, they all over 12 years to 16 years. You can get at smaller lesions or accessible. Surgical resection, depending on the place of the lesion or the AVM. Complications, of the AVM or from the treatment of the AVM in the brain are all pretty much the same. Stroke, hemorrhage, seizures, developmental deficits, paraplegia. I can't stress enough, like every brain AVM, it's a team approach to each patient on an individual basis. Because it depends on where the lesion is. Is it near any centers that in the brain? Sometimes we'll do a functional MRI to see what centers are the lesion is by before we offer any treatment. But it's a complex decision about how to treat brain AVMs in everybody. More clinical manifestation, and that is the GI tract. 25 to 40% of adults have the GI involvement. Unsure in children. You can have upper GI bleeding from your esophagus, stomach, lower GI, and the colon. It can be difficult to treat. May lead to transfusion dependence. I'm sure many of you out there listening are very familiar with this scenario. It can be present at any age. We did have a patient present at 6 months of age with a GI bleed, but thankfully it was one episode. You can have liver involvement, liver AVMs. I have to say that, in our practice, we just don't have that many kids with GI bleed. The GI tract things that we might see are the kids with SMAD4 and the juvenile polyposis, and they require endoscopy for the polyps. But we don't have a lot of kids that have GI bleed. Now just to, as far as, since we talked about pulmonary and brain AVMs, a little bit, what does that mean as far as sports and participation for our kids? There's really not any pediatric data. Adult data suggests there's no increased risk. We're pretty common sense people. We want our kids to participate in sports. There's no evidence-based practice data stating that asymptomatic or symptomatic kids can't play sports. We have real concern about head trauma and chest trauma if you have a known PAVM or brain AVM, because we know that those abnormal vessels can be weak and could burst, and we just kind of tell our patients not to play big contact sports or anything like that if we know that they have these lesions. But again, it's up to the parents, and we don't have any hard data that they should not participate. We haven't had any calls following a sporting event about a patient with HHT having any kind of event or episode either. So this is another area that would be very exciting for research. Well, let's get on to moving along. Screening, hang in there, we're getting there. Screening at an HHT center for kids. So the easiest thing is if we know the mutation, the genetic mutation in the family, from dad or grandma or aunt, then we screen the children for that mutation. They can come to our center for this screening, which is a blood test, or actually it could be a saliva sample for the kids, so they don't even have to get stuck with a needle. There's genetics companies out there, we can just swab their cheek, and that can be done from their home. They send kits to their house. So if we know a mutation in a family, it's very easy to test the children. So once we do that, if the child does not have the familial mutation, that child doesn't need to have any screening. They're done. They don't have HHT. If they do, then we would go ahead and do clinical screening on that child. The other, at the bottom of the screen, if your family doesn't know their mutation, then we would like to start with the genetic test just because it's easier and it's more cost effective if again there's insurance coverage and things to cover the test. But we would obtain the genetic test, which means a blood test on the first person. Most affected, whether it's grandma, aunt, uncle, anybody, or their child, the child's been the first person to have the genetic gene identified. Send the test. If a gene is identified, then we send it on the children or anybody else in the family, and then we just do the clinical screening on those children that have the gene. But also, if in a family, which this is many families, we're not able to do genetic testing, then we recommend clinical screening by those tests that I've described here tonight. Excuse me. But we have to do the screening so that we know, and there's a lot of roadblocks to that. Sometimes it's insurance, cost, coverage, things like that. So screening at an HHT center, again, it's an initial phone contact with usually myself and administrative staff, and we'll do an interview. We'll ask you lots of questions. We will want records, if there are any. We'll review them. We'll review anything you've had with our team. If there's genetic testing available, of course we want that. And then we will schedule an appointment at our center after that's all been reviewed. And again, here we can coordinate the parent visit with the child visit. We even have separate days. The kids are seen one day, parents are seen another day. So if you bring a couple extra hands, we can get it all done in one visit to our center. The appointment is going to consist of a very thorough physical exam, pulse oximetry, which is oxygen level, a brain MRI, bubble echo, chest CT, and we set up other specialty appointments like ear, nose, and throat, ENT, GI, as needed. You know, not everybody gets those appointments, very few, but if that is something that your child needs, then we will set that up at the same visit. Before you leave, you will have results and a treatment plan. We'll tell you when you need to come back, what we are concerned about. Do you have HHT? Might you have HHT? Sometimes we can only say you might because you only have 2 criteria. So we'll have you come back in a few years. But all that will be discussed before you leave our center. Again, frequency, you know, we're still unclear. We kind of say 3 to 5 years because we want to really keep tabs on our little kids and teens. We recommend screening early in life, like within, you know, we wait 3 months of age is pretty much the youngest, unless there's been a problem noted prior to that. In the first year of life, we'd like to see the infant or at least get genetic screening and then go on to clinical screening. Probably teenage, school age years, then like 5 to 8 years later, and then of course late teens, and then adulthood. You know, so probably 3 or 4 times in the first 25 years of life, you should be screened or seen by a physician that knows about HHT. Some of the roadblocks that we run into are not really at our center because we are a pediatric hospital, but you know, we explain the sedation and the need for that because, you know, if the baby's moving, we can't get good pictures in the MRI or the bubble echo. IV access can be a problem in kids, but again, the people in a pediatric institution are used to doing that all the time. Probably insurance is one of those roadblocks where we're still trying to work out. Some insurance companies prevent patients from coming out of state to a center of excellence, and I'm sure other people have ran into that. We really work with you. We have letters of medical necessity, and we try our best to get prior authorization for those visits to our center. We're getting there. So got to get back to these phone calls. So my child has been treated for pneumonia twice, and it isn't getting any better. Could this be something else? Yes. So just at an outside hospital, they weren't looking for HHT. So this person went through 2 rounds of IV antibiotics. When she came here, we found an AVM, and she had HHT, and her dad had HHT, but she hadn't been screened before. We were told we all have a bleeding problem and there isn't much to do about it. Is this true? They do have a bleeding problem, but we want to offer guidance. We want to be proactive, just like you'll see on the Cure HHT website, knowledge is power. We want people to know that there are things we can do to prevent untoward effects like stroke and abscess, and we want people to know what they have and how to take care of themselves. So that's not true. We have things to do to help the patients. I'm pregnant and have HHT. When can we test our baby? Babies can be tested in the delivery room. You can send cord blood for the familial mutation. It can be sent right then, or you can send a blood sample or saliva shortly after birth. As soon as possible, we recommend. Just some generic HHT recommendations for children. Go ahead and embolize or fix those pulmonary and brain AVMs. Always use good nasal hygiene, moisture, avoid trauma, avoid picking your nose behavior, minimize use of any cautery in your nose. If you must, or if it's really bleeding, they recommend low power laser. Avoid aspirin, minimal use to NSAIDs, which is like ibuprofen, because that promotes bleeding. Use a micron filter if you're in a hospital for any period of time and need IV fluid. It removes the air bubbles. Antibiotics before dental work, and we say use antibiotics before anything that's going to cause your gums to bleed or any bacteria that might be shed in the bleeding. And if you don't know if you have pulmonary AVMs or you haven't been screened for several years, then you should definitely use antibiotics before the dentist. If you know that you don't have a shunt on your bubble echo, you do not need to take antibiotics. complete, like a blood count is a good idea if you have active nosebleeding, a lot of nosebleeds or fatigue, pallor, pulse oximetry. Avoid smoking. Everybody should avoid smoking. Sports are okay, usually. Avoid scuba diving, and check with your healthcare provider before using any herbals because they're just not regulated. We don't know what's out there, what's on the market. Just check with your physician or private provider. Visit an HHT center at least once if you can, because they'll give you the latest updates on what is going on in the HHT world. Screening every 3 to 5 years. That's kind of our recommendation right now. Here's our team. And there's just a family. There's Dr. Chacanella and Dr. White. Those are the co-directors of our center. And I would just like to thank you for your attention and that of Cure HHT and all my colleagues here at St. Louis Children's Hospital, WashU, and Barnes, and to all the patients for letting us participate in their care and to make a difference in the quality of their life. We're lifelong learners, the healthcare folks and all of you families, and together we hope to learn best treatment practices for HHT. And again, thank you for your attention.
Thank you, Lynn, for a really in-depth look at children in HHT. I just want to let everyone know that the webinar does only have 10 minutes, but we will go a few minutes over just so that we can get in the questions that people are asking. But before we begin the Q&A period, I want to remind you that there is a section for handouts on the control panel. If you have time to download those 5 handouts before the webinar ends, that's great, but it will be available on our website on the recorded version of the webinar. The handouts will be there as well. So the first question we have is, my husband has lung AVMs and my daughter has a brain AVM. Does exercise or weightlifting increase vessel size or worsen AVMs?
That's a good question. I honestly don't think so, but I don't know that we have the data to say yes or no. That's something I'd be happy to look into. If you want to send me your email or contact information, it's on the screen, but I don't know of any reason that would make blood vessels enlarge. Good question.
Okay. The next question. How are you able to, or are you able to recognize telangiectasias in dark complexioned individuals and or children?
We have some. I think just an experienced clinician can do that. I don't know. I mean, we have patients that have darker skin and we're able to see them. I think we just have to do the rest of the screening. And you can especially look in the oral cavity and the tongue and the lips. The fingers and the other skin, it's trickier, but I think we just have to do the rest of the screening and can't rely on the telangiectasias. Okay.
For children with a positive genetic test, in addition to regular HHT center screenings, what should a parent discuss with their local pediatrician about checking for HHT at a well child visit? And they mentioned pulse oximetry. Are there other things their pediatrician should be doing?
I think that's great. Pulse oximetry, a blood count, depending on how many nosebleeds or if the patient has nosebleeds or any blood in the stool. So a blood count is something that a pediatrician can do. Pulse oximetry, they can ask about exercise, what we call exercise intolerance, or do they keep up with their peers in gym class? Is their child, when they run around in the gym, are they slower? Do they get winded? Those are the questions. Are they ever short of breath? Do they have wheezing? You can ask several questions about the respiratory system. And for sure, a blood count if the bleeding changes. Maybe it's just once or twice a week, but this week he had a nosebleed every day, or she did, and kept him in the nurse's office for an hour or so. So those are things a pediatrician can do. And they can always call, a center and talk to anybody if they have concerns, which I think they should. But
okay, great. Now, this person is asking, why do you say to avoid scuba diving? They have been diving for 10 years and have HHT.
That's good. I mean, so if you scuba dive and are, certified and you do it the right way and you come up slowly and exit the water, it can be done safely. But there are people, if you come up too quickly, gases can be released and it can cause a very painful and sometimes fatal condition called the bends. So you can scuba dive safely, but because we just can't control for that, we just tell people not to scuba dive. But if you're able to do that and you do that well and know how to take care of yourself, then that's great, because it should be okay if you know what you're doing. That's all I can say about that.
Okay. So I have a question, really kind of two questions relating to pulmonary hypertension and HHT. The first one maybe just being more general, like how do you treat a child that has both? But then there is the more specific question about understanding why HHT without AVMs can cause idiopathic pulmonary hypertension, and how might that change traditional treatment methods for PH?
So the first question about medication for pulmonary hypertension.
Well, just how do you treat a child that has both? Like, is the PH maybe primary or the HHT, or does it depend on their symptoms?
It really depends on the patient. I think you have to treat the pulmonary hypertension first, because that causes, heart failure. It really depends. Without knowing the situation of the flow and the hypertension, I mean, some patients are really ill and on continuous IV medications, and others, whatever you treat, it just depends on the patient. I'm taking care of those patients because I worked in lung transplant, but I think you have to treat the pulmonary hypertension first and the HHT symptoms afterwards. But without having the cardiac anything with me, I really can't respond to that anymore, I guess.
Okay. So I know that for HHT centers, there are, I think, 5 or 6, maybe a few more that treat pulmonary hypertension and HHT, that have both specialists. I know that WashU is one of those locations, but I know that's also kind of on the adult side. Does that cross over to the pediatric side as well? Should somebody who has a child with PH and HHT really be trying to get to an HHT center that treats both, even if they're not really a pediatric center, or can a PH doctor kind of treat them locally and the HHT is secondary?
I think it depends on the people you have, but I feel like if they have the PH treated locally, that person could also treat their HHT, even if they're not an HHT center. Yes.
Okay.
That was.
But
yeah,
would you recommend that they come to a center for treatment of both? I
would. But I can't speak. There are probably places that can treat pulmonary hypertension and HHT. I'm not sure.
Okay. So the next question is, this individual's son is 14 years old, and they've been told to wait to have the echo bubble test done. Do you recommend having it done now? He has a positive genetic test and is 3 years old. So I guess, they told them to wait until their son was 14. So they're saying don't do it now when he's 3, wait until he's 14.
There's different professional opinions about when to do the screening, and each center has their own policies and plan of care. We would recommend that he for sure have a bubble echo now at 3. Our center, we have pediatrics, and so we do bubble echoes not only for HHT, but we have a big cardiology division, so they're used to doing bubble echoes. The sooner people know that they have a shunt, the better, because then we can, if he does have a shunt or she, then we would offer prophylaxis for dental procedures. We would follow the AVMs. It doesn't mean that he necessarily needs them treated. We would recommend that he have screening now and not wait till he's 14. But that's just what we do at our center. Every center is different.
Right. Okay. So how early do you clinically screen children? I know you would prefer to have it done genetically, and you said that most children are asymptomatic. So if you do clinically screen children because a genetic test isn't available, is the process different for babies than, let's say, for toddlers or older children?
Good question. No, we do the same test for a baby that we would do for a teenager, meaning the contrast bubble echo, brain MRI, and we do them both infant under sedation. Like I said, if the infant has no problems at birth, we recommend waiting till they're 3 months old just so they weigh a little bit more. But from 3 months on, we will sedate the patients, the babies, and do a bubble echo and a brain MRI. And early in life. So we just say in the first year, but we are willing to set them up at 3 months of age and go ahead and screen them.
Okay. And do you find that children need to be re-embolized, particularly pulmonary AVMs, when they're older?
Good question. And I think this is an area of research that the centers that treat kids are looking into. We have a handful of kids, so 30% of our patients have pulmonary AVMs, and out of those, maybe a third of them have had repeated embolizations. So the answer is yes. It just depends too, like how many feeding vessels they have. And when we do the procedure, we can only use so much contrast at the time. There's a lot of variables. So we embolize the biggest and vessels that we can, but we may need to go back years later, usually not months. It's usually years that we go back and retreat pulmonary AVMs. I think that's a good area of research where there is some gray area about when to treat. If you have a feeding vessel that you can get to that's 2.5 millimeters, do you do that now, or is it okay to wait a couple years? I'm a nurse, but the physicians, I just know that we're looking into that. That's a very good question. I think there's a lot that we don't know yet about timing of the children and repeat treatment, but we have had patients that have needed, because if they have syncope or other symptoms, we have had to do embolization again for different vessels. Okay.
And then let's see. How often should children be clinically screened? And it says, for example, if they were screened in an infant, when would their next screening be done?
We recommend about 5 years. Again, there's no hard and fast data about that. We just feel like we're not ready to say once every 10 years because we want to see the kids and make sure that we're not missing anything, since we don't know how fast. We think the lung AVMs grow really slow, but so we fight 5 years. If we have a negative brain MRI, we'll wait 10, but that doesn't mean we'll wait 10 to see the patient. We'd like to see the patient like every 5 years, at least.
Okay. So this question's kind of general, and it just is, are there any clinical studies taking patients now? I mean, I can say that if you visit the Cure HHT website at www.curehht.org and click on the research tab, there are clinical trials listed there. I know that we are taking children into the brain AVM study, but all the other studies that are listed there are for adults. Are you all aware of any pediatric clinical trials?
No, I just knew, I thought we were still enrolling people in the brain AVM study, but I know like the nosebleed study and other things, it's for adults only. I don't know of any pediatric studies.
Right, okay. And so I would say that our last question of the night is, I'm not always sure who to reach out to for resources. What do you recommend?
I guess it depends on what kind of resources. I mean, I would always advocate for calling a center that's close to you for advice. And then, I mean, the Cure HHT team is awesome. And there's so many resources on the foundation's website, teaching tools for schools, for anybody that wants to know about HHT, family members, healthcare providers. We talk to a lot of people, give them information and resources. I would reach out to a center that's close to you. You want a phone call? It's fine. We can point you in the direction of resources that you need for what situation it is. Whether it's writing a letter about the nosebleeds or anything, I'm happy. I talk to a lot of people. I know the Cure HHT team is always available to reach out for that. So I don't know. Nicole, have anything else to say?
Yeah, I mean, I would say that Cure HHT definitely has those resources. Most of the HHT centers use our resources for their patients. And so again, on the website, under the resource tab, there are different types of resources. The HHT treatment centers of excellence are listed there with the contact information. You should contact the coordinators, and they will actually do that extensive sort of triage call that Lynne talked about, and make sure you get that initial consult appointment and any specialties if you need it. There's also the webinars that are recorded under resources. There are articles, both medical articles, as well as pamphlets, fact sheets, etc. So I think, we're probably one of the greatest locations for resources, and we are completely revamping our website. It's under construction. It's going to be new, interactive, and very, very useful on a lot of ways. We know things are hard to find right now, and so that should be coming out in the next couple of months.
Great.
Okay. And I did say that was the last question, but I am going to ask two more. Do physicians recommend Section 504 plans to have at schools for school-age children with HHT?
You said, do physicians recommend that?
Yes, or would they assist, I guess, maybe in providing that if a parent feels it's necessary?
Yeah, I mean, I'm speaking for my role here at Children's because I do other things and work with adolescents. I mean, it depends on the situation, sure, but if the child has other symptoms of HHT that require that he or she be out of the classroom, then I mean, I think a 504 is reasonable. It really depends on the situation, and but I would think the doctor that has the most contact with the patient would be the person to write the letter or sign the permission slip for the 504.
Okay. And yeah. I'm sorry, last question. If we did not have a genetic diagnosis 4 years ago, is there a chance we could have a genetic diagnosis now? So I'm guessing that they either got a negative or, variant of unknown significance or something like that.
Yeah, I would have to ask the genetic colleagues, but I feel like 4 years ago, there hasn't been enough change to redo the testing yet. Now there is like the whole exome sequencing or the West testing that looks at every chromosome that might have been or could be recommended for some patients. I'm just not sure that 4 years has been long enough to wait. If it was longer than that, maybe, but that's something that I can ask my genetics colleagues. And if you'd like an answer, just I'd be happy to get an email and get back to you. But that's a very good question. I think that's too short of an interval to have had any change for now.
And it is my understanding that if you have genetic testing done, the blood work is kept on file, and you can request it to have it retested in a period of time. So you might want to check with the lab even to see if any new discoveries or new panels are available. So with that, I just want to say that all of us here at Cure HHT, thank you for attending tonight's webinar. Our shared goal is to advance one common hope to give those affected by HHT a chance for a normal life. And this webinar series is just one of many ways we accomplish this mission. We are grateful for the donors of Cure HHT for making this happen and all webinars possible. And we just ask that people consider donating to ensure we continue to offer high quality education for you and your families. You will receive a short survey to complete at the end of this webinar so that we can better serve you in the future. Again, I want to thank Lynne Sekarski for leading this evening's webinar. It was very informative, and it is recorded and will be posted on our website at www.curehht.org under the resource tab. We truly appreciate your participation, and we hope that you enjoy the rest of your evening. Good night.